You can start your session.
Thank you. Good afternoon, doctors. Welcome to this webinar on the role of Oseltamivir in flu management. This webinar is brought to you by Hetero Healthcare, an innovative pharmaceutical company. Hetero Healthcare, the journey began in 1993. We have 30 years of excellence and 36 state-of-art manufacturing facilities. We have 300 plus products in our portfolio and we have presence in 126 plus countries. We have 21,000 employees globally and we are amongst the largest manufacturers of ARV, APIs and FTFs in the world. We have Asia's largest API manufacturing facility at SEZ Complex, Visakhapatnam, Andhra Pradesh. Hetero Healthcare is 360-degree solution provider, striving to fulfill unmet healthcare needs, reaching to customers across India with wide product range encompassing multiple specialties, pioneering in quality and innovation, and we have distinction of bringing 4 biosimilar products to market within 5 years of initiation. During COVID-19 pandemic era, Hetero Healthcare, the pioneers in antivirals, offered Oseltamivir, Favipiravir, and Remdesivir to patients, because of which they received an award of Pharma Excellence in August 2020 for COVID drugs. Today's webinar, Role of Oseltamivir in Flu Management, we have got Dr. Prakash Vaidya as moderator and Dr. Mukesh Sanklecha and Dr. Anil as speakers. Welcome, doctors, to this webinar.
Thank you. Thank you.
Dr. Prakash Vaidya, as we know, sir, is MD DCH and Diploma in Pediatric Sleep Medicine from University of Colorado, attached to Fortis Hospital, Mumbai and Child Health Clinic, Mumbai, Senior Pediatrician with Special Interest in Pediatric Pulmonology. Dr. Vaidya is Joint National Convener, Asthma Training Module, Revision 21-22, Co-Convener and Writing Committee Member of Under 5 Research Modules of IIP, Writing Committee Member of Writing Antimicrobials Responsibly Module of IIP, National Trainer for IIP and TB module, NRC Cup module, etc. Sir has many presentations as faculty at IIP and other platforms and has been past president of IIP, Thane. Welcome, Dr. Vaidya.
Thank you.
Dr. Mukesh Saklaicha, sir, is consultant pediatrician and attached to Bombay Hospital Institute of Medical Science, Mumbai, Saifi Hospital, Mumbai, and has been in practice for past 30 years. The passions of Dr. Mukesh Saklaicha include pediatric allergies, pediatric asthma, pediatric infectious disease, and teaching of. Sir has more than 45 publications in index and international journals and has been a faculty in a large number of national and international conferences. Welcome, Dr. Sanklecha.
Thank
Dr.
you.
Dr. Anil MU, sir, is MBBS MD Pediatrics, Fellowship in Pediatric Critical Care, and Diploma in Allergy and Asthma. Sir is Lead Consultant Pediatrics and Pediatric Critical Care, Sparsh Hospital, Bengaluru. Welcome, Dr. Anil. And with this brief introduction, I hand over the session to Dr. Prakash Vaidya. Over to you, sir.
Yeah, good afternoon. Am I audible?
Yes,
Yes,
sir.
sir, you're audible.
Thank you for those welcoming remarks, and I welcome both my panelists to this webinar. And let me start with sharing my screen. So, is my screen visible to all?
Yes, yes, sir. Yes, sir.
So, today our topic for this webinar is role of Oseltamivir in flu management. And I thank Hetero Pharma for arranging such useful and interactive sessions. So before we go into the discussion, I'm going to start with a few foundation facts, which will regarding the flu virus, the clinical picture of flu, and the antiviral drug. So we all know that influenza is a very widespread disease, and epidemics of seasonal influenza can result in 1 billion annual clinical cases, 3 to 5 million cases of severe illness, as well as almost they are responsible for 3 to 600,000 deaths in a year. So flu is absolutely rampant and it is widespread. The virus is a single-stranded RNA virus belonging to the Orthomyxoviridae family. And we know that there are 4 types of influenza viruses in existence: A, B, C, and D. A and B cause annual epidemics. A also causes pandemics. Type C is a less common disease with hardly any symptoms, not very common in human beings, and D is only in cattle. So the viruses of clinical importance to us are type A and B. A viruses are further classified into subtypes. Now, this classification depends upon the surface proteins of the A virus, and we know that there are 2 surface proteins that decide. One is the neuraminidase and the other is the hemagglutinin. So hemagglutinin and neuraminidase are the 2 large glycoproteins on the outside of the virus. HA or hemagglutinin causes binding of the virus to the target cells and entry of the virus into the target cell, whereas neuraminidase is responsible for releasing the virus particles from the infected cells, the new virions. So HA allows the virus to enter and NA allows the new virus particles to exit the cell. Thus, these are targets for antiviral drugs, and also these are antigens to which antibodies can be raised. So what about influenza A and B? As of March 24, there are two types of influenza A viruses circulating in humans. These are AH1N1 and AH3N2. Influenza B viruses are not classified into subtypes, but they are into two lineages, the B Yamagata or the B Victoria. Now, what are the symptoms of flu? The symptoms are like any other disease: fever, headache, myalgia, cough, rhinitis, ocular symptoms. Only flu is a viral disease. It is a disease with multi-systemic presentation. So you can get CNS presentation like headache, nasopharyngeal problem, runny nose, systemic of fever, coughing, gastric symptoms of vomiting or diarrhea, joint symptoms, muscular symptoms, extreme tiredness. So it's a pan systemic disease like any other virus. The duration is 2 to 7 days, and flu symptoms, they say, are an exaggeration of common cold symptoms. So severity of flu is subjective and inconsistent, but it is like a common cold, except that it is much more severe by and large. And now let's come to a small discussion on antiviral drugs. So the first set of antiviral drugs that were available is adamantine drugs, amantadine and rimantadine. These are history. They are no longer used because the resistance to them is quite widespread. Which brings us to the neuraminidase inhibitors. These inhibitors, as I already told you, prevent the release of virions from the host cell into the circulation. That means they stop the virus in its tracks by preventing it from multiplying. So these are active against both influenza A and influenza B virus. Apart from this, there are other drugs available like baloxavir, which works by a different mechanism, and favipiravir is an RNAP inhibitor. Of these, baloxavir is not yet available in India. It is a drug that is still under trial in our country. So which are the available antivirals which are available? Neuraminidase inhibitors are oseltamivir, the commonest one that we use. Then intravenous peramivir, inhaled zanamivir and laninamivir. But none of these are available in our country. So today we will only be talking about oseltamivir, which is most widely studied and available. Also, it's a new antiviral drug, baloxavir, which has a different mechanism of action. But as I mentioned, this is also not yet available in our country. So to come back to oseltamivir, the only relevant drug for us, this was approved for medical use 26 years back in the US in 1999. It was the first oral neuraminidase inhibitor. And it is a selective inhibitor of neuraminidase enzymes, and therefore it prevents the influenza virus from replication and in fact stops it in its tracks and prevents further spread of infection. Oseltamivir is converted to the active form of oseltamivir carboxylate in the liver. So how does oseltamivir work? It prevents the virions of the virus from entering the circulation and preventing it from multiplying, and therefore it prevents the disease, halts it in its tracks. With this foundation of something about the disease, something about the virus, and something about the drug, I will now invite my panelists to give me their views as I go into some cases. My case one is a 2-year-old boy who comes with high-grade fever, cough, cold, who is actively interfebrile initially. Initial period is active. But on day 3, he has become lethargic, his intake is poor, and there is some dehydration. And clinically, it looks like an influenza-like illness for which I have admitted this child. So let me start with Dr. Anil. Dr. Anil, what is the DD of this ILI? What else will you think of here?
So we usually think about respiratory viral illnesses. Other non-influenza respiratory viral illnesses is at the top of the list here. So we have an entire list starting from a rhinovirus, adenovirus, metapneumovirus, flu viruses. All these viruses can present with ILI like kind of a syndrome. So the differential diagnosis is respiratory versus means
Can
that's
we
a
actually distinguish flu from non-flu type of RTIs?
flu is usually quite severe, abrupt in onset, very high grade fevers, body ache, all these things will be there. But on the initial day one and day two, it could be a problem to differentiate between the flu and the non-flu viruses on day one and day two. Also, we should also keep dengue in mind because dengue also, we are running through an epidemic in the monsoon season. When we get a flu season, we also get cases of dengue. So we should be little careful.
What about your perspective, Dr. Mukesh? Do you think dengue can be kind of confused with flu, at least in the beginning?
Less likely, but yes, we know that flu may come with non-respiratory symptoms, and once in a while, the unusual dengue may come with respiratory symptoms. So yes, there is a little bit, but by and large, I would think a dengue will come with non-respiratory symptoms in
But
most
at a
cases.
time when both dengue and flu are prevailing, I think it is quite prudent to think of dengue as a possibility when you're faced with an ILA-like illness,
Fair
influenza-like.
enough.
Yeah. So, Mukesh, is there any way to distinguish between severe flu and non-severe flu? What are the factors that distinguish between the two?
So, so basic pediatrics comes in here. The child is inactive, dull. The interfebrile period is still, the child is not up on his toes. He's not accepting feeds. He's not sleeping well. He's looking sick. So the child does not look well. Was actually an essay when in the earlier days when in MD pediatrics the fourth paper was an essay. There was in 1 year, this essay was this child does not look well. That is the kind of emphasis that we as pediatricians put on how the child looks. So the child looks unwell, or if his vital parameters are impaired, he's tachypnic, he's having desaturation, or even his pulse oximetry is slightly low, his respiratory rates are high, he looks dehydrated, his oral intake is not good, his urine output is not good. So these things would tell you that this is probably not a run-of-the-mill flu, and it may go into something more sinister.
Okay. So, what are the red flags when you're seeing a patient with an influenza-like illness, Dr. Anil? What are the red flag signs in the child that will make you worry about this child?
Yeah,
Anything
red flags.
what Dr. Mukesh said?
Yeah, red flag signs is number one, extreme lethargy. Child is unable to feed himself or herself. Child is unable to feed. Then we start seeing systemically, if we go respiratory wise, we start seeing that the child becomes little tachypnic, unable to accept feeds. Then neurologically, child becomes lethargic, dull, very sleepy, and these are all the symptoms that we look at. So respiratory wise, it may progress on to develop a full blown pneumonia or ARDS, and neurologically they can become comatose or start having seizures, or they
Right.
can go into an encephalopathy kind of a situation.
WHO
So these
defines
are red
influenza
flags
by,
that we come across.
yeah, by sepsis, septic shock, severe pneumonia, acute ARDS, multi-organ failure, and these patients typically require hospitalization, sometimes even ventilation, HFNC, etc. Uh, Now, coming back to my child, the child who is admitted, Mukesh, how will you manage this child? That this child, particular child who is admitted, he's come with 3 days of fever and lethargy. How will you admit it? How will you manage this child?
Probably this child is hospitalized, his oral intake is poor, he'll probably be on IV fluids. In the influenza epidemic, even before we confirm or rule out influenza, we would probably put the child on Oseltamivir. He has come with respiratory symptoms. He is hospitalized. There are red flag signs. So you would send the works initially. You would send his blood count. You would do an X-ray. You would probably send a blood culture. You would do a influenza swab.
Yeah.
So that's what your initial steps would be.
But would you start him on Oseltamivir upfront before the swab report comes?
So this is a child who's just about 2, in the danger age group. He is in the middle of an influenza epidemic. You have hospitalized this child. So clearly the onus is you simultaneously send a flu investigation, but start oseltamivir empirically without waiting for confirmation of the disease.
Absolutely. So I think your index of suspicion is high enough for you to start Oseltamivir upfront here in an admitted child who has come with lethargy. Uh, let's look at another case, which is a little different from the first one. This is an 18-month-old child, Shlok. He had a past history of a typical febrile seizure. Now he has got fever on day 2, and he had another short-lasting febrile seizure at home. But by the time he has come to your clinic, he is active, so we don't admit him. He's sent home on symptomatic treatment. His intermittent high-grade fever continues, but he is active interfebrile. And he is brought back again the next day with another short-lasting episode, and this time we admit him, though he is now quite active. So I want to know from both the panelists that in this kind of situation, do you feel that you will give oseltamivir upfront or you will wait? Dr. Anil, to start.
Yes, sir. This is a 18-month-old child. So this would come in a high risk kind of a category. Less than 2-year-old would be a high risk for influenza-like kind of an illness. And we are in the middle of an epidemic that's going on for the flu. And this child we have treated symptomatically on day one, sent back, now sick enough to get admitted. He may be admitted for us other cause like a febrile seizure kind of a cause, but till we know more as to how this is going to progress, I think this is we will suspect flu and probably starting an oseltamivir prophylaxis, provided there are no other focus, nothing else to explain his febrile illness. I would go ahead and starting on
The
oseltamivir.
child is sick enough to get admitted. By and large, in the flu season, you will not withhold oseltamivir, but you might investigate at the same time. Do you agree, Dr. Mukesh?
So this child has come with a non-respiratory presentation. We all know that it does happen in flu. My influenza test will come back in about an hour's time. So if I send a multiplex PCR, I'll get the results maybe even in 30 minutes.
But
So
influenza tests can take longer. I mean, it's you're lucky to be in a hospital in a modern city, in a
yeah,
metropolis where you get in an hour. But in a smaller area, it can take even 12 hours or even 24 hours for the flu report to come.
no. So if it's going to take that long to come, then you would be justified in initiating oseltamivir. But this child is, though he's had one seizure earlier and one seizure now, he's hemodynamically stable. You have hospitalized him. What is the indication of hospitalization? Is it the seizure? Is it the high grade fever? Means, are there any red flag
I get
signs in
your
this
point.
child?
So this was not hospitalized for a severity of flu. It was hospitalized for an coexisting cause. So
Correct. So,
you're probably a little reluctant to start upfront.
so Prakash, there are no red flag signs in this patient, are there?
Right. I agree with you. So
So,
this is a little gray area where in a flu season you might start in a hospitalized child. And the other important thing is that does the seizure have any relation to the flu virus? What do you guys think?
CNS complications are a known thing of the influenza viruses, even
Right.
though because there is a past history here, this may be just a simple typical febrile seizure, maybe the second episode, but
And more
still.
importantly, the child has not become comatose. He's become active after the seizure. So probably less likelihood of an encephalitis.
while we know that neurological manifestations do occur in influenza,
Yeah.
to think of it upfront would be a little out of place.
So would you think, Dr. Anil, that this is a neurological manifestation of flu, or it's not there? I mean, you were saying something
May
else.
not be. If you tell me, sir, that the child is becoming active in between becoming active and playful, it may
Yes.
not be a neurological because flu is usually a progressive kind of a disease if left untreated.
Correct.
So
So,
it's
but however, we
starting.
keep in mind that it can be flu, that
Sure.
flu can cause a CNS problem. Yeah. So curiously here, when we did the flu swab, we found influenza A detected. Influenza A subtype was H3N2 not detected, H1N1 not detected. So this was a completely surprising report where neither H3N2 nor H1N1. So it was some other type. So I don't know whether this is one of those real unusual reports, but the point to tell you is that though these two other strains in circulation, there could be other strains as well causing disease. So let me take a corollary to this case that this child was active when you saw. He did not have a second seizure. He did not have a third seizure. He had only one seizure. And the mother comes back the next day also. The child is still running fever, but still playful in the interfebrile period. Still oral intake is fair, not great, but fair. It's passing good amount of urine. Now in this patient, OPD patient, he is not admitted at all. Are there indications for oseltamivir? And I'll ask Dr. Anil first to take this up.
So we start oseltamivir only if there is a high risk patient. High
Yes.
risk as in age group wise, if they're like less than 2-year old, they deserve to be started. If they're more than 65-year-old adult, yes, because the age group wise, their immunity is less, we need to start. And any other comorbidities are there, like that someone who is on immunosuppression for whatever reason, maybe nephrotic syndrome, maybe a cancer chemotherapy that's going on, or a primary PID kind of a disorder. So all these people who have a less immunity need to be started, or they're in the high risk zone, will have to be treated with oseltamivir. So
Okay. What
this
about
child,
you?
considering 18-month age, with fever, with little less oral intake, probably in this middle of this epidemic, yes, probably we would go ahead and start him on oseltamivir.
What about Dr. Mukesh? What would you say?
So I think this child is the same child with febrile seizure, right?
Yes, but he's not did
He's,
not
he's,
give us.
he's come to the OPD, he's stable. Again, no red flag signs. Intake is
Yes.
good, urine is being passed. So this child, I would not start oseltamivir. I would wait and see.
I think
This
it's a
child,
little gray area where some may start
fair
and some
enough.
may not start. Okay.
Fair
Yeah.
enough.
So, so which are the high risk children for which you will start oseltamivir upfront? And maybe Dr. Anil, you could tell me about that.
So age-wise, like we discussed, sir, anyone who is less than 2 years of age, especially, we would go ahead and start. Children who are born preterm or near preterm, they have a chronic condition. It could be a pulmonary disease like asthma, cystic fibrosis, BPDs, or any serious kind of diseases. They have a renal insufficiency, liver diseases, metabolic diseases, type 1 diabetes, and especially in our urban cities, we should not be forgetting obesity. If someone's BMI is more than the 95th centile for age, these children form high risk children for developing complications of flu. So, especially when we come across obese children, we should go ahead and start. And of course, any child who is immunosuppressed for whatever reason, chemotherapy or post BMT kind of a thing, or congenital or acquired immunodeficiencies, we need to go ahead and
This
start
is a
them on.
table from up to date, which Dr. Anil has so beautifully explained that which are the kids who are having coexisting problems. You will start oseltamivir upfront. But Mukesh, could there be any other reason in a non-high risk child on a OPD basis to start oseltamivir?
That's actually a difficult question to answer. And Prakash, I know where this is coming from. Because if you look at data across the world in terms of influenza and serious illness and deaths, 50% of all hospitalizations occur in otherwise normal children, and same data occurs with deaths. So how do you decide in a low risk patient when to start oseltamivir? If there is an influenza epidemic going around and you have a child who comes with respiratory symptoms and the symptoms seem moderate to severe, you would start oseltamivir. The hospitalized child, the child in the ICU, even if they are otherwise non-high risk categories, you would still give oseltamivir.
Yes. But what I wanted to say was children with high risk contacts, they also deserve oseltamivir. So if a child has got a high risk contact at home, then to protect those contacts, you will give oseltamivir to the child. And Dr. Anil, could you just elaborate on this principle?
Yes, sir. Some of the grandparents, if they're aging, if they're more than 65 years of age, they have other comorbidities like severe diabetes, they're immunosuppressed with probably chemo or any other renal insufficiency, they're severely diabetic, they may be obese, all these other things are there, then we need to start them on.
So sometimes you have to start
treatment.
oseltamivir to protect the contact. So one would be very low months. Any contact who's got a sibling who is below 6 months of age, a very young sibling who has got more chances of getting high flu, which is severe, or a very elderly person above 65 with comorbidities. Those are the two extremes. Or any somebody of any age who is on immunosuppressive therapy, some youngster with a malignancy, the child is on immunosuppressive therapy. We don't want to expose this child to the flu virus, so we would start oseltamivir for the OPD patient who may not need it on his own merit.
Also, a pregnant mother in the house.
Or a pregnant mother in the house. Okay. So let's take a few more questions about this. So in your practice, when do you give oseltamivir? I think you have partly answered that. Serious patients and OPD patients who are, high risk as well as with high risk contacts. So Mukesh, what I wanted to ask you was, have you ever used oseltamivir in a case which did not have respiratory symptoms? Is it possible that you can have a non-respiratory presentation of flu which will require oseltamivir?
Sure. So if you have the moderate to severe presentation, the hospitalized child or the child in the ICU with non-respiratory symptoms and is severe enough during an influenza epidemic, then you would use oseltamivir pending investigations. Similarly, if you have children who are below 3 months, there is data across the world which documents the non-respiratory presentation of influenza in smaller infants. So in those group of patients, despite no respiratory symptoms, you may use oseltamivir. Also, influenza in the early stage may come with other symptoms like high fever, even a convulsion, and respiratory symptoms may then appear later on. So yes, you could use you may diagnose influenza in the absence of respiratory symptoms and use oseltamivir in those group of patients.
So let's say a patient comes with high fever and loose motions in the flu season. Would you think that this could be flu?
No, I think if it is isolated gut involvement, less likely. The
What about
probability, as we always say, that multiple mucosal involvement is a virus. So little cold, little
Dr.
cough.
Anil, what would you like to say? Add here?
Now, if it is only a GI involvement, we wouldn't think of a flu upfront. So if
Yeah.
it's a multisystemic thing, they have some conjunctivitis, multiple mucosa being involved, little
Right.
bit of eye congestion, they have a runny nose, they have a sore throat and non-productive cough with GI symptoms, we may think about it.
And of
Not
course,
isolated GI symptoms.
right. Another notoriously non-respiratory dangerous presentation is the CNS manifestation that you mentioned, where you can get encephalitis, and that's where you can think of giving oseltamivir. So I want this as a personal take and a personal practice point from both of you. Do you guys always do a flu swab when you give oseltamivir, whether you give before starting oseltamivir or I mean, rather whether you start oseltamivir or you wait for the swab or you start upfront? Do you always do a swab during oseltamivir therapy? What about Mukesh?
So the decision to start oseltamivir is not based on a result coming back. Your decision is based on the prevailing influenza epidemic and the presence of a high risk child. Whether it's a red flag or it's a hospitalized child, you would start oseltamivir. Oseltamivir is started, the flu test is sent in the hospitalized child, and both are done simultaneously rather than one after another. So you are starting your oseltamivir pending your flu test, but you are starting it. You're not waiting for the results to come and a confirmation of the diagnosis.
Okay. But now suppose you have a child in a hospital or even in an OPD basis. Usually would you do a test in an OPD basis child? How often would you do it?
No, I don't think so. I think your assessment of initiating oseltamivir would not be based on investigations, would be based on the categorization of the child.
What about you, Dr. Anil?
No, sir. As a protocol, I don't think so. We do any kind of testing on OPD basis if the child is well in category A mild flu-like illness. We know that it is self-resolving. We usually don't test them nor start them unless those
All
specific
the
indications are there.
protocols do not tell us to do flu swab on a OPD basis, but I must confess I have done it rarely when some parent has been very insistent that I want to test also. So that is their lookout. It's a harmless test, and if
Yes.
they are ready to pay for it, so be it. So I do it sometimes, but not as a rule. So now we have a child.
So Prakash, I have had patients who come back from in office practice with a multiplex PCR. You are talking about just the flu test, but they have spent $15,000 on a multiplex PCR on an OPD basis.
Yeah, so they would probably not grudge paying the lab as much as they grudge sometimes paying for advice, but that's a different story. So what to do if the swab, suppose you started a patient on oseltamivir and the swab has come negative. How do you react to this? Let's start one by one. Dr. Anil and then Dr. Mukesh.
Yes, sir. The sensitivity of the latest generation of PCR is quite good. I would say probably 95% is the sensitivity of a well-taken swab. If it is positive, it is positive. So at the same time, the specificity is almost close to 95 to 100%. It is specific.
And what
So
about
when it comes,
sensitivity?
so once a test comes negative, most probably it is negative unless some other virus pops up in the multiplex PCR. We know that we could attribute all these symptoms to that virus.
Yeah.
But if it is negative and our clinical acumen is still saying it's a influenza-like kind of an illness, I think it is worthwhile, unless we don't have any other alternative diagnosis, it is worthwhile to stay on the oseltamivir because we don't know how well the swab is taken. If the swab is taken anterior, it doesn't have enough particles, so the sensitivity will drop down to 60%.
So otherwise, you said the sensitivity is around 90%?
95 and above, sir.
And what about the specificity?
100%, almost close to
So
100%.
this is important. The specificity of flu is 100%, means if the swab shows flu virus, it is likely to be the culprit.
Hello?
Yeah. Hello? Am I audible?
Yeah.
Yes, sir. We lost you for a while.
Okay. So, Mukesh, what is your take on this? What to do if the swab comes negative?
So absolutely, even if the swab comes negative and I have a alternative convincing diagnosis, I would pull out oseltamivir. But if there is no convincing alternative diagnosis, I would continue oseltamivir, irrespective of whether swab is positive or negative.
So I think the decision has to be taken on a case by case basis. But the guidelines say that if you have a swab which is negative, you may stop the antiviral drug. Again, the advantage is whether you're doing a multiplex PCR, whether versus you're doing a flu swab. Because in most cases, the multiplex PCR is more expensive than the flu swab. So you may get a flu negative, but we don't know what other virus is there. So Mukesh, do you do a multiplex PCR as a rule, or you do only a limited flu swab?
So if I think if the patient is in the ICU and is critical, I would err on the side of a multiplex PCR in the quest for a specific diagnosis, because the margin for error is rather small.
Right.
Whereas if it's a stable patient who's hospitalized for observation, then I would probably do a stepwise testing.
Okay. So I think the PCR is most hospitals bundle flu with RSV also, but other viruses are not there, and doing the multiplex is a much more expensive proposition than doing the flu alone. What about you, Dr. Anil? What is your practice?
Sir, for the OPD patients, very specific testing we would ask for only for the flu panel. If they're sick, I think I'll agree with what Sir has told. If they're very sick, yes, we would err on the side of adding more viruses at the cost of at a higher cost.
Okay. Now I'm sharing a
Not just
table.
that, Prakash, the multiplex PCR will give you other bugs also, no?
Absolutely.
You have atypical mycobacteria. So there is
atypical mycobacteria would not be there, I believe, in a nasopharyngeal biofire. Do you get those? I mean, not in our hospital.
No, you get if you do a lower respiratory tract biofire,
No,
only then.
I'm talking of a nasopharyngeal swab.
Correct.
Where you get number of viruses, and there are only 3 bacteria where you get pertussis, parapertussis, and chlamydia, I guess. Mycoplasma and chlamydia.
Correct.
So, yeah, so basically we don't get, but then other viruses are also revealed.
Sure.
Now, this is a table from UpToDate which shows you the antiviral therapy choice with suspected or confirmed influenza, and you will see that at all levels, severe illness, non-severe illness, the drug of choice everywhere is oseltamivir, though in an older child it is baloxavir, which is not available in our country, and inhaled zanamivir, which is also not in our country. For all practical purposes, it is oseltamivir only. So I'll take one more case. I have a child with a breastfeeding. This is a breastfeeding mother with a 2-month-old infant. She has moderate influenza symptoms. Her physician wants to start oseltamivir, and she rings up you, Dr. Mukesh, and says, "Doc, is it safe for my baby if I take oseltamivir?" What will you say?
So clearly, here is a contact of a high risk patient. The infant is 2 months old. He is at high risk for severe influenza. So an ideal candidate for the mother to take it. In terms of safety, I think the drug has excellent safety profile, and guarded indications are there even in very small infants for its use. The safety profile being so good, I think you have to reassure the mother that she must take the drug for the benefit of the baby rather than her own benefit, and therefore we reassure this mother. She
So
must
it
take
benefits both the baby and the mother, right? Now I'll ask one more
Not
question.
the mother, no, Prakash. Mother is not at high risk. She has delivered the baby. So
But she has moderate symptoms, and the physician wants to start from the mother's perspective, not from the baby's perspective. He feels
Fair
that
enough.
she might worsen,
Yes.
because even actually post-pregnancy is a little immunocompromised state.
Fair enough. So their indication is twofold.
Yeah. So Dr. Anil,
Yes,
does
sir.
the baby need prophylactic oseltamivir in this situation? What do you think?
Usually, if the baby is less than 3 months old, there is literature-wise, we should not be starting them on prophylaxis. Usually, beyond 3 months, yes, we can start them on prophylaxis, because less than 2 years, it's a high
This is a
risk.
2-month-old baby. He doesn't really qualify for prophylaxis, right?
Yes, sir.
Yeah. But the baby has any severe symptoms,
So
or
we
the
can
baby
go ahead
starts,
and treat.
then we should go ahead and treat the baby with oseltamivir. The point is that this is a table from UpToDate again, where infants who are even preterm, below 28 weeks, only there they say that consult with an specialist in pediatric ID, but anyone between 28 weeks to 37 and above can be given oseltamivir, though the doses you have to realize are a little lower than the doses which are normally recommended. But they can be given at any maturity, at any age which is above 3 months. Below 3 months, you take it on a case-to-case basis. But is there any lowest age where you can give oseltamivir, Dr. Anil?
So
They
14
can't
days
give-
and above, that is 2 weeks and above, yes, that is indicated for therapy. But if they're really sick, we
Yeah.
have gone ahead and treated even
So
less
it's a-
than 2 weeks old, or even in fact, preterm babies also can be treated if
So
the
there is
children
no
are
bar
sick.
to giving it if the baby is very sick, but otherwise the limit is 14 days. But again, there are always exceptions, and sometimes as a life-saving measure, you have to give it. So we come to one more case. This is an 11-year-old boy with fever, vomiting, cough, cold, and altered sensorium for 2 days. Looks like some sort of a acute febrile encephalopathy. You have done an X-ray test which shows haziness on the right lung, and the child was intubated in the ER and shifted to the PICU for further management. His lumbar puncture was done and the CSF was normal. He was started on IV antibiotics after sending blood culture. IV antiviral. Now here I am talking about that we are giving anti-herpes drugs here, that is acyclovir and other symptomatic treatment. The labs on admission were quite unremarkable, and but the nasopharyngeal multiplex PCR detected influenza AH3 and the CSF meningitis panel was negative. Now, in this scenario, Dr. Anil, what will be your actions?
So this child is definitely acute febrile encephalopathy, quite sick enough to be on intubated on ventilator. This is straight away category C, and probably the sickest of the patients we do get. So such patients need to be in the ICU. They are started on empirically on a IV antibiotic, and also considering that influenza is the one of the most common causes for febrile encephalopathy, we do go ahead and start them on empiric oseltamivir even before we get a swab. Here, mind you, in the CSF, it's going to be negative because it may not be a direct viral invasion, but it's an immune mediated kind of a process where influenza can precipitate this kind of an encephalopathy and bring about changes in the CNS. So the virus isolation is still from the nasopharyngeal aspirate and the swab, which is the diagnostic material over here. Whereas the CSF meningitis, even the cell count is going to be normal, and even the multiplex PCR run on the CSF is going to be negative for influenza. So in this case, we are going to demonstrate influenza from the respiratory tract, and we are going to correlate because usually that's the most commonest thing for febrile encephalopathy kind of presentation in such kind of an
So I think
epidemic.
two take-home messages here. One is that here you're going to use a surrogate like a nasopharyngeal swab and not the CSF to demonstrate the virus, because the virus, the biofire in the CSF does not include influenza. That is one thing. But a nasopharyngeal swab would show it, and you can definitely feel that the child would that this encephalopathy can be due to influenza and deserves oseltamivir. The other thing is that in a flu season, or maybe even otherwise, when a child comes with a febrile encephalopathy, do think of flu as a cause, which is one of the treatable causes. So to continue with this case, the neurologist reviewed the child and opined as viral encephalitis. He continued to have fever spikes. On day 2 of hospital stay, the child developed symptoms of acute kidney injury. EEG was normal, MRI was also normal. So, Dr. Mukesh, is this AKI in any way related to the flu virus? What do you think? Hello? Hello, Dr. Mukesh, can you hear me? Hello?
So I'll take this, sir. AKI, yes, because flu, it's a multisystemic illness and it can be a progressive illness. Sometimes it can go on to lead to AKI. It can go on to lead on to liver involvement or a renal involvement also. So any progressive multisystemic kind of an illness, yes, flu is a possibility and definitely needs to be treated with oseltamivir over here.
Right. So AKI is a known cause, and there are papers where flu virus has even caused acute kidney injury. So keep it in mind. Mukesh, can you hear me now? Mukesh?
Yeah, I can hear you. Prakash?
I think
Yeah.
you are off the
Yeah.
net for a while. Yeah.
Yes, for a
Yeah.
second.
Yeah. Can you tell me what you wanted to add something?
Yeah, so though AKI is documented in world literature, I think the incidence is rather small.
Right.
So to consider flu as a a causative agent of AKI upfront is a bit challenging. Even in an encephalitis, since your case presented with respiratory symptoms, I think doing a flu swab made sense. But I would have not asked for it upfront, Prakash. Only
So
when your
right.
initial investigations did not reveal anything, would I have thought of doing a flu swab in this child. But it was wonderful that this came positive and you got a diagnosis.
So it's that whatever treat what is treatable. So now this child has come to you at the age of about 4 to 5 days after the onset of symptoms, because he was initially in a peripheral hospital and now transferred to you. So Dr. Anil, so late in the illness, is it worth giving oseltamivir now?
Yes, sir. Definitely, yes. We know that giving oseltamivir within first 48 hours has got the best response. It will prevent the progression into complications, and also the duration of the flu illness. It's going to reduce by 24 to 48 hours if it is given in the first 24 to
Right.
48 hours.
Right.
But if someone's so sick who is presenting to us on day 4 to day 5 and who is going on progressing, having a multisystemic involvement, having started with the respiratory, CNS is involved, now the renal system is getting involved, definitely this child needs to be treated to prevent further progression of illness. As we know, it will inhibit the further release of the virions from the body, infecting many other cells. So it is worthwhile to start, even though it is late day 4 or day 5, we need to start.
So the take-home message is it is never too late to give oseltamivir. Yes, it is possible that it is best to be given in the early stage, but even it is like a case of never, better late than never. If the child is sick, it is the flu season. Even if he has come to you late, it is worth giving oseltamivir even at a later date. This is what the standard guidelines are saying. So this is the WHO algorithm for treating influenza. Suspected or confirmed influenza, is it severe? And we mentioned what is severe, give antiviral. If is the patient at high risk of progression to severe illness, does he have comorbidities, is he at extremes of age, then you give antiviral. If none of the above, no antiviral. Same with if this is prophylaxis, again, persons with exposure to influenza virus, exposure to a seasonal virus, is there risk of high risk of severe illness, compromise, is he at extremes of age? And here they are saying 85 years or over, not even 65. 85 years or over or younger, patient with multiple risk factors, then you will give prophylaxis. Whereas if it is exposure to a zoonotic virus, which is not a regular virus, you will still give prophylaxis. So let's go to another case now. It's a
At the
6-year-old.
same time, Prakash, if
Huh.
you have a patient who comes with respiratory symptoms, is improving, and for some reason somebody tests him for influenza and he comes positive, and he's
Right.
clearly improving, you would not start oseltamivir on the
Yeah,
fourth,
you
fifth
probably
day.
will not interfere at that point, even though the specificity tells you that it is influenza, but then he's clearing the virus on his own. So I think that makes sense that if a child is person is improving, why would we add an antimicrobial? So this is a 6-year-old boy with an influenza-like illness, and you propose starting oseltamivir on day 3 of his illness because the child looks sick, looks like typical flu. But the mother protests to you that he has received flu vaccine, doctor. Should I still? So Mukesh, what is your reaction here?
So we know that the flu vaccine is one of the less effective vaccines. We give it because we don't have a choice with something superior, but the efficacy is just about 60% on an average. So a child who's received the flu vaccine in the current year is still at risk for getting influenza. So irrespective of whether the child is vaccinated or not, if you suspect influenza and it's a high risk child, you would give oseltamivir.
Okay. So, Dr. Anil, you would agree with this, that flu vaccine would not have a role in deciding whether to give or not?
Yes, sir. Yes, sir. Because as we know, the flu viruses are very much known to undergo this viral drift and a shift kind of a phenomena. So whatever the strain, it keeps on changing on its own slowly. That is what we would call as a.
And of course, as Mukesh mentioned, the flu virus has an efficacy of maximum 65 to 70%, which still leaves a good 30% unprotected even after taking the vaccine. Would you guys do a flu swab here or not?
No, you would
No,
not.
sir. Not.
Because this is clearly an OPD patient. So in short, treatment should be initiated if required, whether or not the patient received the influenza vaccine, and do not delay if you're awaiting the results of viral testing. Also, a rapid diagnostic test. We are not talking of PCR. A rapid diagnostic test does not exclude influenza. We already know the sensitivity and specificity of the of the test, as Dr. Anil mentioned, 95% sensitivity and 100% specificity. Also remember that a positive test for influenza does not mean that there cannot be a co-infection. So co-infection with SARS-CoV-2, and I have personally seen at least 3 patients in this last flu season where it was influenza plus RSV, both as a combination. So now I think all of us are using oseltamivir regularly in practice. So please share your experiences. Are there any adverse reactions? Dr. Mukesh first and then Dr. Anil.
So by and large, oseltamivir is very nicely tolerated by all patients. Virtually, in my personal experience, I have found very little in terms of adverse effects, whether acceptability or otherwise. Gastric irritation, nausea, vomiting has been documented in literature. But by and large, I have observed that it's more of a textbook adverse effect and not so much seen in actual practice. So the drug is very well tolerated.
Yeah, you agree, Dr. Anil? What is your
Yes, sir. The drug is very well tolerated. Very rarely, yes, like sir told, they do come back to us with little bit of nausea and vomiting after taking this medicine. And that is also self-limiting. It happens with 1 or 2 doses, and usually we break it into much smaller doses and administer, or sometimes we will be forced to start a PPI or appropriate treatment for GER kind of measures. I think
I
it will
agree that
settle down.
personally, I also had a lot of usage of oseltamivir. Rarely are there side effects, but there are some patients who get proper GERD symptoms, and you may need to give antacid or PPI in those patients. And now an adverse effect is mentioned in Japan. There are neuropsychiatric effects, but there they use a lot of oseltamivir. It is widespread, and a causality has not been established of this. And it is also said that some of these neuropsychiatric adverse effects may be due to the virus, not the treatment. So another common question which mothers have is that my child has got a flu-like illness. Okay, doctor, you have treated him. When can I send him to school? Because they are in a hurry to send to school. The child is also in a hurry to go to school. So what are your answers? Dr. Anil first and then Dr. Mukesh.
Yes, sir. We know the period of infectivity is 1 day before the onset, and they can shed viruses up to day 7. If the child is in a preschool, they go on shedding these viruses and spread the disease. So better that they stay at home. But actually, the CDC tells us 24 hours of fever-free period, and that well period is what is required. I think going by personal recommendation, I'll tell them at least 4 to 5 days of staying home will help the child. More so, it will help the other children who are going to the daycare or the school.
Perfect.
So
But
I
I
think.
think the parents usually don't listen. So then CDC has a guideline that they children with an ILI stay from school away until 24 hours after their fever has resolved without antipyretics. So 24 hours of afebrile phase when no antipyretics are used, that is the time the child can go to school. But as you rightly said, 5 to 7 days is the best time. So Mukesh, does it mean that if you are giving oseltamivir, the child can go earlier to school is what the mother wants to know?
So yeah, probably the answer is yes, no, Prakash, because it reduces the duration of symptoms by a day. And since it's an antiviral drug, it would therefore reduce the viral load and reduce virus shedding also. So a oseltamivir treated child would be less infective for a shorter period of time compared to a non-oseltamivir treated child.
Correct. So oseltamivir, perhaps maybe they can go, but the guidelines will say that regardless of the child, whether viral or antiviral therapy is there, you can use this recommendation. At least he must be afebrile for 24 hours without antipyretics. But as Mukesh rightly pointed out, the chances that child will be infective are much less in a child given oseltamivir. Now, many times in fever, indiscriminately, we've seen antibiotic use like cefixime or coamoxiclav. Now, does a diagnosis or a diagnosis of ILI help in antimicrobial stewardship? What do you think, Mukesh?
Yeah, Prakash, I think it does. Once you get a specific diagnosis, if I have a hospitalized child, it's a clear-cut viral presentation and his
Hello?
it's a viral presentation and
Yeah.
his influenza test comes positive, I
Hmm.
would certainly either not introduce or withdraw antibiotics that I have used. So
Yes.
yes, it does help
So
in
I can give
antimicrobial
illustration of this.
prophylaxis, undoubtedly.
I had a 10-year-old boy who came with fever with rigors and his had largest tonsils. So my resident doctor who was helping me in the OPD said that, so this is follicular tonsillitis. but actually they were tonsillar crypts, and they had some food particles, so they were looking like stray follicles. There was no lymphadenopathy. We did a flu swab here, and the flu swab showed influenza A positive. So we gave oseltamivir and we avoided added antibiotics. So yes, I can give you lots of examples where AMS is AMS is achieved by using oseltamivir and doing the test. But Dr. Anil, on the other hand, do you think that oseltamivir is used rather indiscriminately today? What is your take on this?
Yes, sir. Sometimes, yes, like we discussed, especially when it comes to the prophylaxis part, giving prophylaxis to a healthy adult or a healthy parent at home with no comorbidities is not indicated. So we are exposing this molecule to developing resistance over here if it is used indiscriminately. At the same time, there is lots of, even in this epidemic, there is a lot of resistance in starting oseltamivir where it is indicated. I think we should have a balance in this.
So I think
Especially when it comes to prophylaxis, we should be very careful.
correct. So one more case I'll take. 11-year-old girl, fever since 2 days, high grade, relieved on medication, dull interfebrile period, breathing difficulty, bronchospasm, tachypnea. And this child was admitted last month with influenza A to another hospital, and now she has come to me. So here, Mukesh, this child has already suffered from influenza A, already has received oseltamivir last month. How will you manage her now?
So we know that influenza can occur again. We know there are multiple strains. We know, and this child is demonstrating danger signs. She's an unwell child in the ICU, I believe, since there's
Yes.
difficulty in breathing. So this child would still start empiric oseltamivir pending investigations. Of course, you'll probably start antibiotics. You would give a bronchodilator because of the bronchospasm. So this child would require polytherapy pending investigations. So as you have rightly done, you'll have started antibiotic, given azithromycin, started oseltamivir, and nebulized the child. So you start off with a serious child and polytherapy.
Oseltamivir, even though she has received it last month, because the current situation warranted that, right?
Absolutely, because multiple strains, you can get a second flu infection in the same season with a different strain.
So you said it, Mukesh, this child swab showed influenza B plus RSV. So this was a back-to-back influenza A followed by B. So the moral of the story is, given oseltamivir last month does not contraindicate giving it immediately again if the child's clinical situation at that time warrants. So this was the X-ray. So when during oseltamivir therapy would you give antibiotics? And just a quick one-line answer because we are running out of time. So Dr. Mukesh followed by Dr. Anil.
Difficult, no? See, patients with influenza are prone to strep, pneumonia, Streptococcus pyogenes, staph, and it can be bad infections. So if patient is a sick patient in the ICU, like your ventilated patient, if the patient is not improving despite 40 to 72 hours of oseltamivir, or if the patient has improved and then deteriorated, or if your investigations document something towards the bacterial infection, you would start antibiotics.
Anything to add, Dr. Anil? Because
yes, sir. If at all there is any localizing to one system where we have a lobar pneumonia or anything which localizes, yes, we have a high index of suspicion and start on IV antibiotics.
So flu is a setting for secondary bacterial infection. If the child is still running fever and has evidence of a concurrent bacterial infection like a localization or maybe rising counts, CRP, neutrophilia, you'd probably want to start an antibiotic also.
Fair enough.
Something about oseltamivir prophylaxis before we finish, and I want a quick one-liner because we are actually running short of time. So if the child is admitted with you, it's a 3-year-old child, would you give prophylaxis to the parents of an admitted child?
Healthy parents, no, sir. Parents with comorbidities, yes. Probably we would give a
Healthy
prophylaxis.
parents, no. Okay. Grandparents of the discharged child, now who may or may not have comorbidity, we do not know. But usually at that age, it is very unlikely that there is no comorbidity. So Mukesh, would you give it to the grandparents?
Above 65, yes.
You'll give oseltamivir prophylaxis.
Above 65, yes. If they're young grandparents, 50-year-old, no.
So, okay. So now this is the child, 2-year-old, who is going home, and he has a younger sibling at home who is 3 months old. So here, will you give the younger sibling oseltamivir or not as a prophylaxis?
No, sir. 3-month-old, it is not indicated that we
Not
give, sir.
recommended.
6 months old.
No, sir, still.
Okay. So some references will say that a younger child would require because we don't want it to be exposed. But again, this is a little bit gray area. But I think 6 months old, there may be some studies which will say give it. So post-exposure prophylaxis, according to WHO, is intended only for individuals if they would have an extremely high risk of hospitalization if they contracted influenza, and should not be arbitrarily expanded. And post-exposure prophylaxis does not replace influenza vaccine. Now, this is a child with croup who had come to me, and a throat swab was done. The child had a lot of cough, respiratory symptoms, high-grade fever, and it showed the para-influenza virus in the swab, in the multiplex PCR. So should I give oseltamivir here, Dr. Mukesh?
No, it doesn't work against parainfluenza. It works against only influenza.
Dr. Anil?
No, sir, not indicated in this case.
So take-home messages, there may be influenza in the name, but not influenza. It's not, it's para-influenza. So oseltamivir does not have a role. So in all these years that you use oseltamivir, is there any contraindication to oseltamivir? I would like both of you to take it one by one.
No, sir, I don't think so. There is an absolute contraindication. Is only the hypersensitivity which is documented, which is again very rare. But it's a very well tolerated drug, and usually there are no contraindications, I would say. Little bit of caution is required when we are using it in renal impairment. Caution is required, but no complete contraindication per se.
Dr. Mukesh, anything to add? Is there any...
Exceedingly well tolerated, good safety profile, easy to use.
Yeah. So I think there may be relative contraindication because sometimes the child may have, say, gastric bleeding, GI bleeding, or a bowel obstruction where you can't give oral drugs. Unfortunately, there also somehow we have to find a way to give oseltamivir because in our country, the IV peramivir is not available, nor is the inhaled zanimivir. So we may have to give oseltamivir even to those patients, but those are relative contraindication. Pregnancy, would you give it in pregnancy? So there are a lot of observational studies during pregnancy where they find that it is safe, no malformation, no fetal toxicity, and pregnant women are actually high-risk women when the benefits of using the drug are far better, far more than the risk of harm to the baby. So yes, it is not a contraindication at all. So what about oseltamivir in a child with kidney disease or renal disease? Is there any modification of the dose required, Dr. Anil?
Yes, sir. We will have to reduce the dosage if there is a renal insufficiency.
Yeah.
Probably this is one of the few relative contraindications where we need to be cautious about the dosages used.
Correct. So there is no contraindication with a renal issue, but there is you will have to reduce the dose.
Caution is required for the dose.
As per the creatinine clearance in a child with kidney problems. What about vaccine and oseltamivir? Is there any kind of interval required between oseltamivir use and flu vaccine? Mukesh?
Yes, so since it's a killed vaccine, I think the interference is minimal. So if you have recently given the drug, for a few days you don't give it. But by and large, otherwise, there is very little contraindication.
So you said it that the interference is minimal. In fact, the WHO guidelines are saying that you can give even antiviral flu medication should not be you can give it with inactivated. So while the child is on oseltamivir, you can still give him flu vaccine. That suppose he's on prophylaxis and you want to immunize him, you can give. There is no contraindication. But there is a problem with the live vaccine. Live cannot be given for 48 hours after stopping the drug, and the drug should not be given for almost 2 weeks before giving the live vaccine. So if the live vaccine is given and you give oseltamivir within 2 weeks, the immunity is suppressed. So also you can't give the live vaccine 48 hours within 48 hours of stopping the drug. So only after 48 hours. But there is simply no problem with the inactivated flu vaccine. So we've had a very lovely session with both my panelists giving perfect, crispy answers. So we have covered a lot of ground. So just to sum up before I stop sharing my slides, in India, oseltamivir is currently the only anti-flu drug available. It is a very useful drug in treatment and prophylaxis, but there are specific indications. So use it timely and use it wisely, and we should avoid indiscriminate use of oseltamivir. With that, I will stop sharing my screen, and I thank the organizers again, and I thank both my panelists for giving very, very perfectly relevant and precise answers to allow us to cover this topic. Thank you.
Thank you, sir. Thank you
Thanks,
for the
Prakash.
moderation, sir. Thank you.
Thoroughly enjoyed your moderation.
Thank you.
Thank you, sir.
So it was a very elaborate and informative session. I'm sure our audience must have benefited with the in-depth insights on Oseltamivir. So I thank on behalf of Hetero Healthcare, I thank all the three doctors, Dr. Prakash Vaidya, Dr. Anil and Dr. Mukesh Sanklecha for this wonderful session, and also thank the audience for the attending this program. Thank you.
Thank you.
Thank you so much. Thank you.
Thank you, sir.
Thank you, sir.
Okay, see you.